So all attendees should be on mute. Type in your question and comment in the chat box. When you see that during the presentation there is something you want to ask, please use the chat box. And this will be 90 minutes session. Let's be respectful of each other's opinion. And our hashtag for today is ECSACONM Webinar 25. Please use that to tag. And we have our moderator. I'll introduce her. Her name is I don't see the name, Julius. So she's a lecturer at the School of Nursing and Midwifery and Paramedical Science of Masinde Muliro University of Science and Technology in Kenya. And she has 20 years experience in clinical practice and close to 10 years as a nurse educator. She holds a Bachelor of Science in Nursing, Masters of Science in Nursing on the areas of maternal and neonatal health. And she's currently a PhD nursing student with bias to midwifery and reproductive health. Beatrice is committed to training and mentoring future midwives and nurses and improving maternal and newborn outcomes in Kenya. Her research interests include maternal and child health, reproductive health, and adolescent health. She has widely published in a peer-reviewed journal and presented several papers in local forums. She is a member of several professional nursing organizations, including but not limited to ECSACONM, Nursing Council of Kenya, Nursing, NNAK, and MAK. So you are welcome, Madam, as our moderator.
Thank you very much, Amy. Okay, maybe my name was not, I think it was an oversight. My name is Beatrice Mukabana, and it is the way Lemmy has said. So I'll straight away go to the agenda items of the day, and we are going to have an opening remark, then we are going to have our webinar objectives read to us. We are going to have next introduction of the panelists, then panel discussion and presentations will be the next agenda. Then we shall have questions and answer sessions from which we shall have our next step and then vote of thanks. So our opening remarks will be made by our very own Madam Lemmy Mabuka, who's a Senior Program Officer in ECSACONM. Lemmy, welcome very much and give us our opening remarks. Thank you very much.
Thank you so much, Madam Beatrice, our moderator. And I would like to greet you all. Good afternoon, everyone. It is my pleasure to welcome you to today's webinar on managing high-risk pregnancies, a midwife's perspective. The topic is both timely and vital. As midwives continue to play a key role in ensuring safe outcomes for mothers and babies, especially in high-risk situation. I know we are all from African countries, but we still face very high mortalities and mobilities on maternal and neonatal death. I thank you all for joining us and encourage open engagements as we learn, share, and strengthen our collective efforts in maternal health. With that, I now declare that this webinar is officially open. Thank you. Back to you, Madam Moderator.
Okay, thank you very much, Madam Lemmy, for those good opening remarks. I will straight away go to our webinar objectives. Remember, we are looking at high-risk pregnancies, specifically midwives' perspective. So to achieve that theme, we are going to have 3 objectives, and the first one is identifying high-risk pregnancies and common complications. The second one is evidence-based approaches for effective care during prenatal, intrapartum, and postnatal periods in managing high-risk pregnancies. Then finally, we are going to look at interdisciplinary collaboration in maternal care. So those are the objectives that will drive our webinar this afternoon. So we have 3 panelists who will take us through the 3 objectives. And our first panelist is Christina Japotela Mbiza. She'll be taking us through identifying high-risk pregnancies and common complications. Christina is a midwife or midwifery specialist from Malawi. I've seen someone talk about us telling you where we are coming from. Christina comes from Malawi, and she has over 20 years of experience. She's a registered nurse midwife, educator, and researcher, currently working at Queen Elizabeth Central Hospital in Bulatyre. Sorry if I don't pronounce it well. Christina holds 2 master's degrees, that is bachelor's in nursing education. She's involved in national health committees and serves as board at Kamazu University of Health Sciences. Her passion lies in adolescent pregnancies, labor care, with several publications focused on maternal health and collaborative practices in maternity units. Then our second presenter or panelist is Dr. Anne Wawire Kabimba. Kabimba will be taking us through evidence-based approaches for effective care during the prenatal, intrapartum, and postnatal periods in managing high-risk pregnancies. Dr. Anne is a dedicated and inspirational midwifery educator and researcher with a PhD in midwifery at Moi University School of Nursing and Midwifery in Eldoret. She brings us over 30 years of experience, over 35 years of experience in teaching, preceptorship, and curriculum development. She is passionate about evidence-based and contributes. She champions midwifery led care to improve maternal health outcomes, and has also led research projects and collaborations with the Nursing and Midwifery Council of Kenya, Moi Teaching and Referral Hospital, and international university exchange programs. So that is Anne. So our next and the last presenter is Esther Banda. Esther will be taking us through interdisciplinary collaboration in maternal care. Esther is a maternal and newborn health advisor, family health and nutrition project in Zambia, with over 20 years experience in maternal, newborn, and child health specialty. She holds a Master's of Science in Nursing with bias to maternal and child health, and another Master's of Project Planning and Management. She has been a lecturer, midwifery, for over 10 years and has so much passion for the midwifery profession and saving lives of mothers with their babies. She is a nurse and midwife specialist. So those are our panelists for today. And kindly, if you have any questions, you can send them to the chat box so that we shall look at them. Now we want to welcome our first speaker, who is Christina Japotela, to take us through identifying high-risk pregnancies and common complications. Madam Christina, the floor is yours. Welcome. Thank you.
Thank you so much. I'm going to take you through identification of high-risk pregnancies. And let me start with the introduction. The major goal of prenatal care is to ensure the birth of a healthy baby while minimizing risk to the mother. And to achieve this goal, one of the major components is identification of pregnancies at increased risk of maternal and fetal morbidity and mortality. Therefore, risk assessment is part of the prenatal routine care. And the risk factors, as midwives, we must assess them systematically because each risk factor increases overall risk in pregnancy. Therefore, midwives, we are key in assessing and identifying risk factors early and even during pregnancy to prevent maternal and fetal morbidity and mortality rate. So this is going to be my outline. I'll start with the definitions of high-risk pregnancy, risk factors, signs and symptoms, how we identify the risk factors, and then finally complications. So how do we define a high-risk pregnancy? A high-risk pregnancy is a pregnancy that carries increased health risks for mother, fetus, or both. And pregnancy, it is also a pregnancy in which fetal and maternal outcome is not as good as the control population, the low-risk mothers. So these are the layman's definition. But according to WHO, a high-risk pregnancy is where the mother, fetus, and both are at higher risk of experiencing health problems or complications as compared to a typical low-risk pregnancy. And this pregnancy is defined also as a low risk when it requires multidisciplinary specialized care. We know that if it's a high risk, multidisciplinary team is involved. And sophisticated maternal and fetal surveillance is also involved. And in many occasions, difficult management decisions are needed to optimize the outcome. Next slide. So what are the risk factors? They are categorized into maternal factors, lifestyle factors, pregnancy-related health conditions, and maybe medical conditions. But let me start with the maternal factors. In the maternal factors, we have age. If the pregnancy is less than 17 years, if the woman is pregnant and she's less than 17 years old, it means she's at risk. That's a risk factor. Because we know that normally this is a teenager and she usually has consequences during pregnancy and even after birth. And if a woman carries the pregnancy after 35 years, she's also at risk because there are also some problems that she may encounter during the pregnancy. Obesity is another factor. If the woman is obese, she can also have some problems like pregnancy-induced hypertension, sometimes gestational diabetes, and also eclampsia. Height is also another risk factor, one of the maternal risk factors, because if the woman is less than 150 centimeters high, we know that she can have problems during pregnancy or even during delivery, because usually she has CPD, cephalopelvic disproportion. And another factor is granulomatoparity. If the woman has pregnancies up to maybe 5 or more, that means she's also at risk. So she's also considered as an at-risk mother. She needs to be cared appropriately. Another factors are lifestyle factors like smoking, substance use disorders, or alcohol use disorders, or maybe if a woman is exposed to certain toxins, she can also be at risk because if the woman is smoking or having alcohol, she can have complications during pregnancy, even after birth, even after delivery, and even the child can also have some congenital abnormalities. Pregnancy-related health conditions These are conditions that arise during pregnancy, like such as gestational diabetes mellitus, pregnancy-induced hypertension, preeclampsia, antepartum hemorrhage, and even multiple pregnancy. So these are the conditions that arise during pregnancy. So as a midwife, we need to also know these conditions. We also have pre-existing maternal medical conditions. These are conditions a woman can have before pregnancy, such as chronic hypertension, diabetes mellitus, renal diseases, or thyroid diseases. So as a midwife, you need also to assess this woman properly to identify these pre-existing medical conditions. Next slide, please. Yeah, other risk factors are history of previous pregnancy. So this is very important when we are correcting the history from the woman to know about the recurrent miscarriages, stillbirth, preterm labor, and if there are history of small for gestational age or even congenital abnormalities. This helps us to know how we are going to manage this woman during antenatal period. Obstetric conditions such as blood group incompatibility, multiple pregnancies, abnormal eye, or even malpresentations are very important to identify also during a pregnancy. Gynecological conditions such as polycystic ovarian mass, uterine fibroids, uterine septum, incompetent cervix. A woman is supposed to be assessed on this. Just as a midwife, you need to find out if the woman has these gynecological disorders in order to give her appropriate care during labor and also to have a good delivery. And also postnatal care, if she might develop complications, we will be able to manage her properly during the postnatal period. Fetal factors such as genetic abnormalities, structural abnormalities, prematurity, and these are some of the risk factors, and the fetal growth restrictions. This can be detected during pregnancy or even through fetal scan. What are the signs and symptoms? As a midwife, sometimes you need to know the warning signs of risk factors. This can help us to know that because of this sign, the sign that I have identified, this woman is at risk or she can have complications during pregnancy. Signs such as abdominal pain, severe, it's an indication of could be ectopic pregnancy, severe pelvic pain or cramping or contractions. It can indicate that maybe this woman is having a preterm labor or threatening labor. Chest pains might indicate that this woman might have pulmonary embolism or cardiac disease. Dizziness or fainting, extreme fatigue is an indication of anemia in pregnancy, reduced or no fetal movements, heart palpitations. If the woman has tachycardia, it really shows that she has a problem. Severe nausea and vomiting. Of course, we have minor disorders, but if the vomiting is severe, it means that this woman has a problem and she needs to be assessed appropriately. Maybe it might be a sign of multiple pregnancies. Severe headache and blurred vision, which could indicate preeclampsia or pregnancy-induced hypertension, generalized swelling, the same problem. Shortness of breath might indicate a number of conditions, cardiac disease or pulmonary embolism, vaginal bleeding or spotting, which might indicate maybe the woman has ectopic pregnancy or antenatal antepartum hemorrhage. Leaking amniotic fluid or fever and chills might indicate some infections, or maybe the woman has malaria, which is common in our region. So these are very important warning signs for midwives to know in order to manage this woman properly during pregnancy. How do we identify these risk factors? Early identification is very important. This can be done through preconception assessments. But in our region, especially in our country, most women, they don't go for preconception assessments. So we can say that preconception assessment is very important, and mostly we might refer these women when we identify them during pregnancy, and then refer them if they have a complication, and refer them to attend to do preconception assessments if they want to conceive again. But early and thorough prenatal care is also very important. Because since most of the women, they don't go for preconception care, early and thorough prenatal care is also very important for us to identify these risk factors and complications. And during this antenatal care, we also need to correct accurate subjective data and objective data. This might help us to know that this woman is really at risk, and the objective data might also help us to identify these risk factors. Frequent monitoring will also enable us to identify these risk factors, because we cannot just check the woman on an initial visit. Even when this woman is coming, she needs regular prenatal visits, and WHO recommends 8 contacts. So during these contacts, these women should be fully assessed comprehensively, so that should be able to identify these risk factors. Ultrasound scanning and other fetal monitoring techniques are also important for us to identify these risk factors and to check on the overall health of the fetus and even the placenta. Next slide, please. Yes, still on identification, blood pressure monitor is very important. We know that preeclampsia or eclampsia is one of the conditions that kills our mothers. Therefore, blood pressure monitoring is very important. And this blood pressure monitoring should be regular, and it can be done at the clinic and even at home. The woman can do the blood pressure checks. But maybe in our region, especially in Malawi, we all can have maybe women attending these antenatal care, maybe in the remotest villages where maybe the clinic might not have some blood pressure monitoring machine. Therefore, we can tell the women to go to maybe private clinics so that they should go at least to have a blood pressure check. It's very important. Fetal movement observation is also very important. We need to encourage our women to pay attention to the fetal movements and report any concerns to healthcare providers. As the midwives, we need to tell these women to do that. Still on identification, investigations are also very important. And in our antenatal or prenatal clinics, we do routine investigations. But sometimes, because of the conditions that the woman is presenting with, or maybe the signs that the woman is presenting with, we do the specifics. So we do the routine urine testing checks and also blood testing checks. In blood testing, we can do full blood count to know maybe the hemoglobin level of this woman and other infections which can be detected through full blood count. We need to know the blood group. Maybe hepatitis test is also very important to know if the woman is hepatitis positive, for her to be managed accordingly. HIV test is also very important for us to manage this woman antenatally and to prevent mother-to-child transmission of HIV. Syphilis test, the same. We need to do VDRL to check if the woman has syphilis, to prevent mother-to-child transmission of syphilis. Fasting and random blood sugar check. Of course, in other countries, it's done routinely, but maybe in our case, sometimes we look at the presentation of the woman and do the fasting and do the blood check to check if the woman has diabetes mellitus. And other screening tests might depend on the situation. So warning signs are very important for us to know the type of test that we might do. What are the complications that these women present with? These common complications are preeclampsia, spectrum disorders, or gestational hypertension, preterm delivery, cesarean delivery. This is also one of the complications. If the woman presents with maybe cephalopelvic disproportion, which has been identified antenatally, she might end up with a cesarean delivery. Bleeding, that's hemorrhage. During pregnancy, that's APH, and even after pregnancy, postpartum hemorrhage. This is one of the complications. So maternal sepsis, one of the killers of our mothers, maternal sepsis. Therefore, women need to be identified antenatally if they have signs of sepsis, or maybe conditions that might lead them to have sepsis even during labor and even after delivery. Intensive care unit admissions. In the intensive care unit, we admit pregnant women who are critically ill, or maybe they've delivered and they are critically ill, like those with HELP syndrome, renal complications. They are normally admitted in our intensive care unit. That's why I've put it as also one of the complications. Birth defects, problem with the development of baby organs such as heart and brain. These are also some of the defects. We've also talked about if the woman is exposed to drugs, the baby can have this problem, these complications, or it can be genetic. Neonatal intensive care unit admissions, if the baby has complications during delivery, normally we admit them in the neonatal care unit, neonatal intensive care unit. The baby can have asphyxia, the baby can have maybe with low epigastrol, meconium aspiration, or maybe might develop sepsis. If they are critically ill, they are admitted to our NICU. Miscarriages, stillbirth, these are also the complications that we might need to identify. Intrauterine growth retardation and low birth weight. So these are common complications that as a midwife need to know them and how to manage them. In conclusion, risk factors must be assessed systematically because each risk factor present increases overall risk in pregnancy. And early identification and regular monitoring is very crucial to prevent maternal and fetal morbidity and mortality rate. Therefore, as midwives, we are key in assessing and identifying and managing these high-risk factors and conditions to prevent complications during pregnancy, during delivery, and during after birth. Thank you very much. That's the end of the presentation.
Wow. Wow, that's a great presentation from Christina Biza. Christina, thank you very much. That was indeed awesome. And from what Christina has said, we are all in agreement that our major goal as nurses and midwives is that our major goal of prenatal care is to ensure that the birth of a healthy baby, but while minimizing the risks to the mother. She's gone ahead to talk to us about the risk factors which we should be aware of. And she has also talked about the signs and symptoms and identification, which is very key. Early identification, which should start from all the way from preconception care, is very, very important in minimizing high-risk pregnancies. Thank you very much, Christina. That was very good. So if you have any questions, I repeat again, you can put them on the chat box. They'll be answered at the end of the session. So our next second presenter is Dr. Anne Wawire Kabimba, who will be taking us through evidence-based approaches for effective care during prenatal, intrapartum, and postnatal periods in managing high-risk pregnancies. Welcome, Dr. Anne. Thank you.
Thank you, Beatrice. I hope am I audible? Hello? Hello?
Yes,
we can
you
hear
are
you.
audible.
Hello?
Hello, we can hear you.
We can hear you.
Okay, thank you so much. I'm Dr. Anne Wawire Kabimba from University Nursing and midwifery educator. Thank you so much, Christine, because you've talked quite almost a quarter of what I was supposed to talk about. But here now, let's look at what is evidence-based practice. It is one that is conscientious, explicit, and judicious use of current research evidence, problems, and decision-making. So you have to be very accurate, explicit, and judicious in your decision-making. The aim of this evidence-based practice is to improve maternal and neonatal outcomes, ensure quality care, and reduce unnecessary interventions like what we mostly see in our care practices. The current research evidence calls for access and interpret. You need to assess and interpret the most current research findings, clinical trials, systematic reviews, and WHO guidelines. So as a midwife, you must be on your toes to look at what is happening almost every passing hour. We also need is where individualized care is embraced, and therefore we need to acknowledge each woman's needs and preferences and tailor the care to that particular woman. Gone are the days when we would group mothers in ages of gestation, but now we look at an individual mother. Then translate the new knowledge you have or you have gained into the clinical, administrative, and educational practice. Next. Next slide. Next slide, please. Yes. Our pillars of evidence-based practice, we have 4: research evidence, practice evidence, client evidence, and of course, the conduct evidence, which we have scientific research, which includes scientific research, clinical expertise, and client values. So there are 3 key players here. That's the research, that is the expertise, and the values of the client. So what are the steps that we follow in the process of evidence-based practice? There are 5 A's and 1 E. The 5 A's are assess the client. And when assessing the client is thorough and is inclusive of all aspects of assessment. Then ask a focused question, clinical question. When after you have assessed and you want to ask questions, please remain focused, ask focused clinical questions. Don't go out of point. Then acquire evidence to answer the question. So from the assessment and from the questions you are answering, you are able to acquire the evidence to answer the question of the particular mother in front of you. Then appraise the quality of the evidence. It's not just the question of having the evidence, but is it tangible evidence? Is it evidence that can be replicated? Is it evidence that can reduce the problem at hand? Then after that, apply the evidence to client care. And we say it must be individual client care. And then after you have applied it, evaluate. Okay, you evaluate and see, has it worked in this particular client or it has not? Then what is a high-risk pregnancy, one would ask, is one where either the mother or the baby or both have increased chance of developing health problems during pregnancy, childbirth, or postnatal. Already, Christine has alluded to age bracket, which is below 17 or above that 5, and to add on that, multiple pregnancies. So the risks that we may have to look at in high-risk pregnancy are bleeding, convulsions, headaches, blood vision, edema, abnormal blood glucose, raised blood pressure, and proteinuria. And of course, Christina has looked at the signs and symptoms. Next. So general evidence-based practices in general, we must have early and frequent monitoring, routine and specific. And the event that you're not able to elicit the information you want, then there is technology. So embrace the use of technology. Again, we need to have specialized consultations. A midwife works in collaboration with other practitioners. So consult where you need to consult. Medication management, safe and effective during pregnancy. As a midwife, we don't just give drugs, but we must be sure that the drug you are giving is safe for both the mother and the baby, and effective
Sorry, Anne. Hello?
And
Hello, Anne?
Are you able to hear us, Anne? Dr. Anne? Hello, Dr. Anne?
Post.
Wow.
Not just a question of
Dr. Anne? Dr. Anne, are you able to hear us?
Then we have stress reduction.
Dr. Anne, are you able to hear us?
And how do we reduce
Now, we can't reach Anne.
So maybe we can proceed with the next speaker, and then once internet is stabilized, she can just chip in later.
Yeah, I think you can move the slides to our next speaker because we have lost Anne.
So when these authorities are too many.
Okay, let us have our third speaker. That is our third speaker is Esther Abada, who's going to talk to us about interdisciplinary collaboration.
Hello?
Anne, are you able to hear me?
Yes, Dr. Anne, can you hear us now?
Anne, are you able to hear us?
Yes, I can hear you. I can hear you.
Yeah, your internet was not stable by
Okay,
that
so
time,
Esther,
so maybe we get back.
And we lost you. I think you have network issues. Maybe you can work on that.
Hello?
We lost you along the way. We couldn't.
Can you hear me now? Yeah, I think it's because of internet.
Yeah, we lost you. I don't know if you have found a stable internet so that you... Are you able to hear us?
No.
Anne, can you hear me? Can you hear me, Anne?
Dr. Anne, you have joined with the two device. Maybe if we proceed
I
with
can.
okay, I used to, can you proceed now?
Let me just change the device.
Yeah, sure. Maybe if we proceed, maybe if we proceed with the third speaker, and then you just come after.
Okay, it's fine.
Okay, thank you.
So I think Esther can continue, then we shall have Anne later. So our next speaker is Esther Abada. Esther is taking us through interdisciplinary collaboration in maternal care. Esther, the floor is yours. Welcome.
Beatrice, can you hear me with this one? Beatrice? Hello, Beatrice?
Yes,
Yeah,
I can hear
now
you.
it is stabilized, yeah.
You can hear me now?
Yes, but we have given the floor to Esther. Maybe you can complete your presentation after she's done, if that's okay with you. Okay.
It's fine.
Okay.
All right, thank you so much, and good afternoon, Beatrice and everyone. Hope you are able to get me.
Yes, we can get you clear.
All right, I'm sitting with the country director, Madam Lastina Rwatula, country director for JPIGO, and I recognize all senior midwives and everyone listening in on the forum. So we are moving on to the interdisciplinary collaboration in maternal care. So what are we talking about? We are talking about high-risk pregnancies and then also the care that is needed. We know that as midwives, we are custodians and our expertise is mostly for normal pregnancy, labor, delivery, and postpartum. When we start going the abnormal way, we start seeing the complications, we need other healthcare professionals to work with. So interdisciplinary collaboration in maternal care involves various healthcare professionals working together to provide comprehensive and coordinated care for pregnant women and their newborns. So the midwife is the first person that this woman comes to see, but we all realize that even if we are the first people that they come to see for antenatal care, they come from the community. So like here in Zambia, we have the Safe Motherhood Action Groups and some community-based volunteers that have been equipped to identify women with pregnancies and encourage them to come early for antenatal care. Because once we come early for antenatal care within the first trimester, we are able to find and identify all those women with high risk pregnancies. So what are we saying? We don't want to work alone as an independent profession as midwives. So we have people that we can work with, starting from the community. I mentioned the CBVs, and we are supposed to have public health nurses. I don't know whether we have them in all the 18 countries under ECSACONM. And we also have environmental health technicians, and we are supposed to have community midwives who help us because these women are coming from the community. When it comes to the facilities, we need people who can understand the mental health. We need obstetricians, we need physicians, we need people from the lab. You know, when we are seeing our women like on first contact, there are a lot of screening that we do. So this collaborative approach can improve patient outcomes, enhance care coordination, and promote the well-being of mothers and babies. So according to World Health Organization, collaborative practice happens when multiple health workers from different professional backgrounds work together with patients, families, carers, and communities to deliver the highest quality of care across settings. So high-risk pregnancies benefit from the interdisciplinary collaboration. We have to work as a team. So why is this important? Improved maternal, it increases and improves the maternal health outcomes. Interdisciplinary teams can address complex medical, social, and psychological needs. When we are getting history during antenatal booking, we identify that some women have medical conditions which are pre-existing, others develop them while pregnant, others develop them even while in labor and at the time during postnatal. So then we need other healthcare providers to attend to them. We need physicians. If they have problems with the social problems, the social workers also are needed. Psychological needs, we are all seeing a lot of mental issues now, and pregnant women are not left behind. So they need also other healthcare providers to assist. So this leads to better health outcomes. There's also enhanced care coordination. Collaboration ensures that all aspects of maternal care are seamlessly coordinated from prenatal care to postnatal care, because a complication can occur at any time of this woman being pregnant. And that is why we encourage, when we are attending to these women in our facilities, we need to have a way of tracking them. We can have high risk registers where we have a system of following up to see that they have well attended and a better outcome, positive pregnancy outcome at the end of it all. There's also increased maternal health safety, and by bringing together diverse expertise, you hear from a physician, obstetrician, a midwife, a nurse, and other cadres. This can identify and mitigate risks, ensuring the safety of both mothers and the babies. So there's also improved maternal care access to services. Collaboration can streamline the process of accessing necessary services. We see, especially in facilities where we have different services being offered, you can easily refer to those departments. So interdisciplinary collaboration, how does it work? We need to have regular communication and shared decision-making among team members, which is very, very essential. We need to have joint care planning, develop a shared care plan that addresses the individual needs of the pregnant woman and her baby. We can't do it as midwives by ourselves. So we need other people, other trained people, so that we come up with a concrete plan and we help the positive outcome of both the mother and the baby. There also be shared responsibility. Members of the team take responsibility for their specific areas of expertise, working collaboratively to achieve the best possible outcomes. As midwives, we can prepare this woman maybe who's been scheduled for cesarean section, but then someone from theater also will come and do their part, the anesthetist to come and assess, and an obstetrician is going to work on this woman. So that is collaboration that we need. And continuous improvement, regular evaluation of the interdisciplinary team's effectiveness and ongoing efforts to improve the quality of care. If we improve the quality of care for our women, especially those with high-risk pregnancies, we'll see that the outcomes are going to be positive. So what are some of the strategies for effective collaboration? We need to build a collaborative culture. We need to encourage open communication and respect for all teams' perspectives. We do not need to look down upon, if you are a midwife attending to this woman and maybe a nurse is seeing something that may point to something that may need attention, please, let's not look down on each other, but let's work as a team so that we save the life of this woman. Open communication is very, very important. And we need to define clear roles and tasks. We need to ensure everyone understands their responsibilities and how they contribute to the team's goal. Using effective communication tools also is very, very important. We need to establish channels for communication and use plain language to avoid misunderstandings. We also need to encourage continuous learning, provide opportunities for team members to learn from each other and stay updated on best practices. What are some of the examples of the interdisciplinary teams in maternal care? So we have maternal mental health teams. They include mental health professionals, social workers, and obstetricians. I can hear some background noise. To provide comprehensive support for pregnant women experiencing mental health challenges. There are also, people who are getting pregnant now, even the young girls, we have a problem of teenage pregnancies. So they may benefit also from these people who promote mental health. There are also high-risk maternity teams that involves the obstetricians, the nurses, the midwives, and other specialists to manage complex pregnancies and high-risk conditions. We also have community-based teams. I'd mentioned some community-based volunteers like the Safe Motherhood Action Groups. We need to collaborate with the community health workers, social workers, and other community organizations to reach pregnant women in underserved areas. However, we are promoting effective interdisciplinary collaboration, but there are some barriers, like lack of training and understanding. Many healthcare professionals may not have adequate training in interprofessional collaboration. If I'm a midwife, what I know is just about midwifery. It shouldn't be like that. We need to understand that we work as multidisciplinary teams and we have these boundaries, but there is a time that we want to work collaboratively so that we promote the positive outcome. So this leads to difficulty in working effectively with colleagues from different disciplines. And there's also ambiguous roles and leadership, and clear roles and leadership structures can create confusion and hinder the flow of information and decisions making within the team. There are times that other professionals think they are more superior than other professions, but we need to work as a team so that our goal is the same, to save the life of the mother and the baby. Then sometimes we have communication challenges. Different disciplines may use jargon or have different communication styles, leading to misunderstandings and hindering effective teamwork. In conclusion, we are saying interdisciplinary collaboration is crucial for optimizing maternal care and improving outcomes for mothers and their families, especially for high-risk pregnancies. By fostering a collaborative environment, clearly defining roles and utilizing effective communication strategies, healthcare teams can provide more comprehensive, coordinated, and maternal-centered care. And we should realize that we are talking about interdisciplinary collaboration, but key is the woman who has a high-risk pregnancy. Whatever plan, she should be at the center of the plans that we are making. Thank you.
Thank you very much, Esther. That was indeed a powerful presentation. I know all of us, if we have worked in a clinical area, we have seen that indeed interdisciplinary collaboration works well for our patients. We are dealing with mothers who need holistic care, and what you cannot manage, let your other cadre do it. However, as we try to embrace interdisciplinary collaborations, as she has mentioned it, we have barriers that will hinder us from carrying out effective interdisciplinary collaboration. We should start searching our hearts, and we should start like talking to our colleagues, to the doctors, to the social work, to everybody that is in that clinical area, to preach that for sure interdisciplinary collaboration is the best for our mothers, and especially mothers with high-risk pregnancies. Thank you very much, Esther. That was indeed a powerful presentation. And Wawire, if you are ready, you can complete your presentation. However, Julius, kindly, she's saying you have muted her and she can't unmute. You can do that. Unmute her so that she can...
she has to unmute to mind. I see she has already unmuted.
Okay, okay. So Anne, welcome on board. I'm hoping your net is now stable. Yes.
Can you hear me?
Yes, we can hear you. We can hear you.
Can you hear me? You can hear me?
Yes, we can. And you, can you hear us?
So that we complete.
Can you hear me, Anne?
Put the slide. Yes, I can. Put on slideshow. Yes, I can.
Okay, welcome.
Yes, I can hear you, Beatrice.
Okay, welcome on board.
You cannot hear me?
Oh, I can hear you.
Can you hear me?
Yes, I can.
Can hear you.
Can you hear?
We can hear you.
Slideshow. Yeah, slideshow. Okay. Okay, slideshow. Put for me on slideshow. Julius. So we move to the next slide. Next slide, please. What has happened again? Julius, please, the next slide.
Yes, doctor. Maybe I want to know which screen do you see right now?
Okay. There
Can
you
you
are.
let me know?
There you are. Just enlarge
This
that
one,
one.
right? General evidence-based practice,
Yeah,
right?
I'm there. General. Yes, that one.
Yeah, perfect. You can proceed.
Yes, put it on slideshow.
It is already in the on the slideshow, so you can proceed.
Okay.
Yeah.
Okay, thank you. So we had talked of medication and management, safe and effective. We had talked of psychological support and lifestyle adjustments. Next slide. Next slide. Thank you. So we continue. We have the risk management, where we have counseling, which should be open and free communication and education regarding potential and preventive measures. Empower the client to actively participate in her care. Invasive procedures should be avoided as much as possible, And then collaboration, as it has been discussed, of course, between the community and the community care should be effective and coordinated well. So we must focus the coordination on individualized care plans based on the specific needs of a mother and the baby. Otherwise, you need to utilize a multidisciplinary approach, which we have all talked about, while close monitoring and specialized consultations and measures to prevent. Best practices during pregnancy, comprehensive history, this one we have talked about it, and comprehensive history starts from the time the mother enters the clinic and you assess from there. So there's early identification of risk factors, which my colleagues have talked about. And here we consider periconceptual genetic screening as part of the screening procedures. And then we need to provide protocols on drug and substance use, obstetric comorbidities, especially cardiomyopathies, which do not show any sign but just suddenly occurs. Then we have to look at viral and parasitic infections. We need to embrace prenatal diagnosis, utilize the history, physical examinations, and effective communication, and therefore collaborative care between the healthcare providers, the pregnant woman, and her family. Next. The recommended best practices during intrapartum. The WHO recommends, of course, alongside the national protocols, that which are supposed to be performed by midwives, available research to guide labor and childbirth, and therefore minimize harm and maximize care for the mother and the baby. It should be diligent use of photographs. We should allow mobility, allow preferred birth positions, avoid episiotomies and amniotomies where possible. Demedicalize the mother or the woman, administer prophylactic antibiotics only when it is necessary. Implement newborn care practices like delayed cord clamping, skin-to-skin contact, newborn examination, early initiation of breastfeeding. And then, of course, a new concept of companionship is coming in, information sharing, privacy. Rehydration is very important in labor, feeding the client, mobility, upright positions, relaxation, exercises, and non-pharmacological pain relief. We are saying we want to take away medicines from this mother and allow her to proceed naturally. So key aspects of evidence-based intrapartum care will include labor support, freedom of movement, encouraging breathing out the baby as opposed to pushing the baby out. Then the photograph I've already alluded to it, mobility I've already alluded to it, and birth positions allow the mother to deliver in a position comfortable. She could be squatting, she could be kneeling, she could be standing, or on the side. But the midwife will be there to support that childbirth process. In the newborn care, we have drying and covering, delayed cord clamping and skin-to-skin contact, and of course, early initiation of breastfeeding. We need to minimize routine interventions in mothers and the baby, and of course, the use of oxytocin, which is just routine. Every mother is being augmented. I don't know why. Respectful maternity care is key. We have to ensure that the mother receives respectful and supportive labor and childbirth process. Continuity by midwives is important, and therefore the midwife is supposed to hand over a mother at any cost you are living. So the evidence-based intrapartum care practice, there are 6 care practices that promote physiological childbirth, which we should adhere to as midwives. 1, avoid medically unnecessary induction, augmentation, or of labor. Allow freedom of movement for the laboring woman. Provide continuous labor support. Avoid routine interventions and restrictions, encouraging spontaneous breathing out of the baby. Most of the midwives will put up a drip. Even when the mother doesn't need a drip, she can take by mouth and then tie that mother into bed and tell her not to walk because they will have blood backflow. So we should avoid that. Involves utilizing research findings and best practices to guide care delivery, and of course, we ensure the best possible outcomes of mothers and their newborns. We need to implement interventions that have demonstrated effectiveness, improved patient safety, and satisfaction. And satisfaction here is the healthcare provider, the mother, and the family. Next. We need to utilize the risk. Sorry. Back a little. Okay, fine. We can continue. Okay, we need to utilize research findings and best practices that guide labor. We ensure the best possible outcomes of the mother and implement interventions that demonstrate effectiveness, improved patient safety and satisfaction. I just wanted to emphasize that. Okay. Now, key aspects of evidence-based postpartum care. One, we have early and frequent postnatal clinics. We have home visits, breastfeeding support, mental health screening and support, contraception counseling, pain management, post-operative care, and monitoring for complications. And of course, the patient care, the patient education. We need to educate these mothers. Most of our mothers are ignorant. They come to labor ward and they don't know what labor is. They don't know how to have the baby out. They don't revise, they don't want anything because they lack information. And then improved potential patient outcomes, enhanced quality of care, cost effectiveness. Let's think of how much it is going to cost this mother to have a baby. And then we monitor for complications, patient education again. We have improved patient outcomes and enhanced quality of care, and of course, cost effectiveness. Next. Next. Early identification and management of complications, postpartum hemorrhage, prompt recognition of PPH, still should be provided, active management of that stage. And that one, of course, as midwives, we are aware. And then, of course, infections, we need to keep prophylactic antibiotics for women with 3rd and 4th degree perineal tears. And hypertensive disorders, monitor blood pressure regularly, urinalysis, watch for complications. Postpartum checks, day 1, 24 hours, 2 weeks, and 6 weeks, respectively, to assess physical and psychological well-being, sexual and family planning counseling. So mental health screening and counseling, we need to have the societal and family integration for the mother to understand this aspect. And then individualized care, which should be focused to the baby and the mother. And then early mobilization, exercises, and self-care. Because these mothers will go home and they're kept in the house for how many days before the baby is seen, before they go out, and we end up with problems. Then general strategies of management, we need nutritional support, maternal and newborn care, health quality, adequate resources, effective communication, and client education. So client education keeps repeating itself. In conclusion, by implementing these evidence-based practices, midwives significantly improve maternal and newborn outcomes in high and low and high-risk pregnancies, labor, and childbirth, and of course, postpartum periods. Therefore, research is key to the ever-evolving midwifery practice and a game changer of mindsets, because most of us have mindsets. We used to do this, and you keep doing what you used to do. You don't want to move with the current wave. So midwives are encouraged to move with the current wave. Don't go and get infected with who has been my age mate was in labor ward for so many years and believes hitting the baby's back is the best way. So let's be changes. And as we come, let's go back and give our people this information so that we're able to change and move with the current information. Please read, please keep updated. That is it. Thank you so much. And sorry for the inconvenience of technology.
Good. Thank you very much, Dr. Ann. That was indeed a wonderful presentation. And personally, I always feel happy when somebody is talking about evidence-based, because the way Dr. Ann has said, you go to the clinical and you want to implement something, but then the own midwife there tells you, no, we don't do it. We are not supposed to do it like this. We are used to doing it like this. The evidence that actually made me happy here is when the presenter says, let the mothers breathe the babies out. Let them not push the baby out. We all know, even if you are in coma, you will give. Unmute. Mute, Ann.
Yes.
Mute kindly. So we all know, even if a woman is in coma, she will give birth to her baby. So we let them breathe the babies out. Another one is when we are telling them you are passing the clinical and midwives are like, mama or this woman, let her sleep on a position before she delivers. The question I ask myself always is this lithotomy the best position for the mother, or is it the best position for the midwife? That is food for thought for all of us, the midwives and the nurses here. So thank you very much for those presentations. We now go to the question and answer session. And if we go to the chat box, there are some questions that have been posted there. The presenters, take note of your questions. For example, we have a question for Christina. Christina, you have a question that is talking about, let me see, sorry, I missed it.
In
We
fact,
can
I
see
have
on
two
the
questions.
on a screen. I have shared
Christina,
it.
have you seen your
We
question?
have,
Yes,
we
I have.
Okay.
In fact, I went through the chat and I've seen that I've got 3 questions.
Yes.
One for ICU and NICU as a complication.
Yes.
The other one, cesarean delivery, is it a complication? And the other one, I don't know if it's for me, fibroid uterus. How do you manage a woman with a fibroid during a delivery, during pregnancy? So
Yeah, that's
those are the
yours.
3 questions that I noted. Yeah, so maybe let me start with the cesarean delivery. For a cesarean delivery, of course, cesarean section is one of the quality care, but we should be talking of a previous cesarean delivery as a complication, because if the woman comes with a previous scar or previous cesarean section, we call that woman that she's at risk. She might end up having a complications like ruptured uterus. So maybe when I was talking of cesarean delivery, I meant the previous cesarean delivery as a complication. When it comes to ICU and NICU, is it not a quality care? Why did you mention it as complication? NICU admission or ICU admission, usually, of course, it's one also of the quality improvement care. But if I also explained during my presentation that if a woman is admitted to the intensive care unit, an intensive care unit, I mentioned it as a complication, but if the woman is admitted at the ICU, it means that she has a complication. And this complication needs critical care. We admit conditions like maybe acute kidney injuries, maybe the woman with HELLP syndrome, women with DIC or pulmonary edema. They are mostly the women who needs support, respiratory support. So when I was talking of ICU admission as a complication, I meant to say the conditions that we admit in ICU, the condition that needs respiratory support or critical care, these are the ones that I meant as ICU complication. Same as NICU. If the baby is admitted at the neonatal intensive care unit, it means this condition is the condition of the baby is critical. She might have respiratory syndrome, respiratory distress syndrome, or maybe sepsis, hypoglycemia, she's jaundiced. So these are the cases that we admit in neonatal intensive care unit. So when I mentioned about this as a complication, I meant the conditions that we admit in these areas to be managed as complications. Now, fibroid uterus. How do we manage women with fibroid uterus? How do we manage a woman who has fibroid and get pregnant? Usually, I think we mentioned of collaborative practice here. So as a midwife, your duty, your role is just to assess and identify if this woman has a risk factor, and if she's at a primary facility, she's referred to a referral center or tertiary facility for specialized care. And usually, the doctors, they do wait up until they look at the how big the fibroid is. But in normal circumstances, this woman, when she's pregnant, she needs close monitoring. Normally, they don't remove the fibroid while she's pregnant because we are also afraid of other complications like bleeding. But this woman is monitored closely in case, because she's at risk of miscarriage. She might have antepartum hemorrhage, placenta previa, because of the fibroid. The placenta might not be planted on the normal place where it is planted. Therefore, she's at risk of antepartum hemorrhage and even preterm labor. So normally, and even after delivery, she might have postpartum hemorrhage. So normally they wait up until she delivers, and they wait up until maybe the postnatal period is over, and then referred maybe to the gynecologist for myomectomy. But in normal circumstances, when this woman is pregnant, she's just monitored closely up until she delivers, and after the postnatal period is when she's referred to gynecologist for myomectomy. So this is how I can respond to the questions. Maybe if there are people who can comment or maybe have some additions, they are welcome. Thank you.
Good. That is a response from Christina on her presentation. Unless if someone else has some input to add, we are free to add. We have good comments also on the chat box. You can read them on what Christina presented. Dr. Ann, you also have questions on the chat box. Kindly, can you respond to them? Anne is still maybe preparing. Esther, you have a question also. Esther, have you seen your question?
Yes, thank you so much, Beatrice. I've seen the question where Frederick is saying, do I think we need to broaden our approach from interdisciplinary to multidisciplinary? So the multidisciplinary is different disciplines, but they have boundaries. Different disciplines may work together, but
Hello,
they
Beatrice.
will not collaborate. Hello, so in interdisciplinary now it's different fields, so the two have been exchanged. And I think what we are encouraging is more of interdisciplinary, so that to cater for what you're talking about, Frederick, are those outside the hospital setting. So an inter will do, multidisciplinary will be different professions, but then their boundaries, they stick more to their expertise than just being general. But when we go the interway, then we are going to bring in different people, even administrators, those that are able to help us with the referral systems and other cadres. But multidisciplinary is a bit limited because of the expertise that is from there. We encourage, yes, we work as such, but then you will find an obstetrician when they make an order, there's a specific way that how they want that done. I'll give an example of when we do the ultrasound for a woman. A midwife will have certain interests, want to see, is this a normal pregnancy, what is the gestation age, but a doctor may want to go beyond that. So that is within the hospital setting and multidisciplinary, but inter, we are going in different fields. So that is more wide, and that's what we want to encourage for now, not to be limited within the hospital setting. Thank you.
Good. That was elaborate enough. Anne?
Hello, Beatrice.
Yes, Anne, you had questions on chat box. I don't know if you have seen them. Maybe you can respond to them.
I've not opened. Oh, just outline them for me, because some kids are not active.
Okay.
Can you just outline them for me?
Okay.
Yeah, I can
Julius, you can
read.
outline that.
Yes, I can read number the question from Anna Modong, sorry. Hello, Dr. Anne. I have not heard you talk about mental support in preventing postpartum blues. If you can also talk more on the counseling, on the contraceptives, it is still lacking behind.
Thank you. I think I talked about mental health, and I talked about counseling, where we involve the mother and the family and the society for them to understand. Maybe she missed it. And then family planning, I've also alluded to the family planning. And family planning, here we don't just give family planning. Evidence-based is that you really have to examine the mother and see what suits the mother. The mother may want a coil, but does it suit her state, her situation? So it is you, the midwife, to analyze evidently that a pill would be better than a coil for this mother because of 1, 2, 3 reasons. And therefore we talk of thorough history taking and examination and physical examination. Thank you.
Okay, another question is from Alfred, and it is, hi, Dr. Anne, can you elaborate more on non-pharmacological pain relief after delivery?
Thank you. Unfortunately, we are in Africa of this non-pharmacological pain relief, but what they are. Mobility is one of them. Ask the mother to be out of the bed. Don't nurse the laboring mother at 6 centimeters. She's tied into bed. Get her engaged in talking. If you labor, you can have this first stage mother sitting together and discussing as they continue laboring their first stage. And of course, in labor ward, like our labor wards, most of them were.
I think Anne has disappeared again.
As the contraction goes away, let them discuss. The next mother can tell the other one how hers is so severe, and the other one will tell her.
So there was another question for Anne again.
Severe. Talk to them.
How can we minimize routine use of oxytocin? But I think someone has already answered that. Yes, Anne, your network is still unstable. Yes.
Yes. Routine oxytocin. Yeah. Why are midwives giving oxytocin for augmentation? Why are you augmenting at the labor at 6 centimeters, 7 centimeters? What is your reasoning? Okay. So let's be objective. But if don't just go to pharmacy because you want to go out for oxytocin and add. And the funny bit is that when oxytocin is added, and this one most midwives will agree with me, they are never monitored. So it runs. It is through. Or the patient, some patients are very clever. I don't want this drip. So she opens it, it runs through, and then you come and it's finished, and then you bring another one. So let's be objective. Objectivity is one of the evidence-based practice. Thank you.
Thank you very much, Anne. I think we come to the end of our question and answer sessions. Kindly, if you have something pressing, you can always get to the secretariat. We'll get your answers. We now move to our poll and discussion session. And I think I will hand over to the secretariat. Julius, I think you can take over from here. Guys, thank you very much, participants, for being active. Thank you very much, the panelists, for the good presentations that you have given us. Thank you.
Yeah, thank you so much.
Okay, back to you, Julius.
Thank you so much. Thank you so much. So, dear participants, thank you for your participation in this webinar. For the part of the polls and discussion, I just want to emphasize everyone to go back to IECO platform. I just want to demonstrate to you here how you can fill the poll, as well as how you can participate in the discussion. So kindly be informed that the discussion, it's normal there within the platform before the webinar, and even after the webinar you can still go and you can be engaged in the discussion with the others participant as well. So let's go together here to the IECO platform, and you will see how you can participate in the discussions. So when you open your IECO platform, when you log into your account, and you are here now in the webinar program, so you will see our today webinar is here, managing high risky pregnancies, a midwife's perspectives. So on top you can see the place written discussion. I hope everyone can see this one. So when you go to a discussion, you are able now to participate to the discussion. We'll just add today April webinar here, so that you can just come. You will see if there is any kind of announcement, and if you click to the conversations here, you will just be able now to participate in the discussion. So we'll just add the topic here for you to discuss. You can just log in, and then you discuss at your own time, and others also they can just chip in and comment on your response as well. So also for those who are asking for the presentation, kindly be informed that the presentation will be added here in the content part. So when you open the IECO, you can just go to the content part, and once you click it, you will find the content over here. So for example, as you can see here, we have the content for the last webinar. It is here already, webinar presentation for the March. So what you have to do, we'll just add for today webinar here. You just have to come to this part written action. So you click on the action, and then you click on view. So once you click view, it will just automatically open, and you'll be able to review it. So based on that short elaboration, let me welcome let me inform you about the next step for our webinar. So our next step will be about the certificate provision, and the certificate will be offered for those who at least engage in the webinar for 75 minutes of time given. Remember that our webinar runs for almost 90 minutes, which is 1 hour and 30 minutes. So what we do, we normally divide it, the time you spend to the webinar, divide by 90, and thereafter, if your time reached almost 75%, if you have attended for 75%, you are qualified to get the certificate of participation. So I just want to encourage everyone to make sure that you join the webinar on time, but also you stay until the end of the webinar, not just chipping in and then you are running from the webinar again before ending time. So also the next webinar will be on our next webinar. You can just see here on the schedule. You just see about the mental. It will be about the mental health and the well-being for healthcare workers. So now this is not about the patient side. We are going to talk about ourselves as healthcare workers. So please make sure that you prepare well, and also you attend even the discussion concerning about the next webinar. So as said, let me welcome Lemi Mabuga to give us the vote of thanks. Thank you. Welcome, Lemi. The floor is yours.
Thank you, team. Thank you, our moderator, Beatrice, and panelists, and Julius, for good organization of this webinar. But I would like to acknowledge the presence of our Vice President, Madam Evelyn Maziku, who will do the closing of the webinar. Madam Evelyn, you are welcome. Please unmute and greet the audience. Hello, Madam Evelyn. So let me give her 1 minute. If not, I can take the responsibility by closing the webinar. Thank you. Let me proceed. I would like to thank you all for joining today's webinar on managing high-risk pregnancies, a midwife's perspective. Your insights and engagement has been truly valuable. Let's continue supporting midwives and strengthen maternal care. I wish you all the best in your continued work. Stay safe and goodbye, but kudos to the team, our moderator, our panelists, and secretariat. And thank you all for joining, and we welcome you to the next webinar on 30th. Don't miss, and let's practice on the new innovation or the good practice that were shared today. And let's show that nurses and midwives can do a wonderful work in saving lives, especially to maternal and child care. Thank you so much.
Thank you.
Hi, Christine.
Okay, bye all.
Thank you.
Thank you. I like the music from Malawi.
Simukuna mako kawizina ne malota ine bambo wanga atandisi enda salandeka kawizina mwe malota ine bambo wanga atamwali enda salandeka gondo mama gondo une mama mwe gondo mama jalamanda tafera mwenda we kondo mama, kondo une mama mwe, kondo mama chala manda utafela mwenda we. Nangomba mbilio, mbili tumaona lero. Nangomba mbilio ka, mbili tumaona lero. Agidesi aimbae zogo matumaona lero ndipo chalamanda aimbae zogo matumaona lero ngamba kuti mwakwatira mwabala mwana woyera zina lache musolo unamva kwa ndani kuti mtakwatira ngamba kuti mwakwatira mwabala mwana woyera zina lache musolo nangopanga chikoso kwatinza kuitana musolo mai musolo mai mana mene ndamai
Julius, can you also drop now?
Now.
Can we drop?